Yeah, it's...
Video started. Wish I could do 2 angles. I'm just gonna get a video of this because you can see us and everything. Cool. Pretty mediocre, but it'll capture everything.
Is this the microphone?
Mm-hmm.
I love how you think it's mediocre, and I'm like looking at it like, whoa,
Yeah,
that's
right.
cool. Mediocre, okay.
Technology.
Down, girls.
Stop.
Imagine if I'd had coffee.
Oh, you haven't yet?
No, because my stomach is hurt.
Did you pour some? Or is that tea?
That's tea. I'm trying to calm my stomach. It's not working.
Oh.
I'm going to shut that door because
I didn't know we were already joined.
watch what happens if I touch this.
No, don't do it yet.
Okay.
Okay, now you can do it. What's happening?
Oh, there it goes. A little bit. It must like... Oh, it went up there. It's a sensitivity plant. Usually when you touch it, there it goes.
Now it's sad. That's weird.
Mm-hmm.
Sweet breeze reply. Reply. forget how to do that flipping thing.
Oh yeah. Oop.
No, I'm not. Kids on.
Yeah.
You won't let almost. Oop.
I used to be able to do it a little bit.
Yeah, I remember you doing that.
Can't do it anymore.
Out of practice.
My name is Pelusiak and the pencil.
Oh, yeah, yeah.
Fun.
Do I look like him? That's my dad.
I was wondering who that was.
He was like 8.
Yes, you do.
Danielle does too.
Yeah, she does.
Oh. Maxine Goyette.
I'm not going to be able to attend the Friday one. So the client may have to miss it all this job.
The mic is muted right now, by the way. You don't have to whisper.
Okay. Have it, I guess. But this recording looks like that'll be good.
Yeah, just have to get another SD card.
The Patriots lost their game last night. Yesterday afternoon. Should have expected it.
It's alright, the Giants lost to the Cowboys.
Did they?
Yep. I hate the Cowboys.
Yeah, I'm not a big fan of Cowboys. Ever since the 80s.
Yep, I've hated them since then.
Yep. I had a friend in Virginia that he was a big Cowboys fan. It used to drive me crazy. He was one of those sore winners.
Ugh.
Yeah.
Yeah, that's kind of that Cowboys MO.
Yes.
What do you have to pet it? Oh wow, look at that.
Yeah.
Did you see that? Watch this. It just like curls up.
Oh, wow.
I think it's distraught.
Looks sad. Don't touch me.
Did it have a top? Or no?
I don't think so. But I don't remember. Oh, now Nikki Owens.
Group meeting. Yes. I just work here.
Apparently this plant is a weed in South America.
But they grow really big.
Sensitivity one?
Mm-hmm.
That's good.
On Tuesday nights when I meet with my friends, I have to keep it away from Judy and Sierra because they're constantly trying to... Do you want one like that or a thicker one? Oh, this flatty. You do?
Yep.
Judy hates these. They give her the creeps. I can't have them around her on her side. She has weird phobia stuff. All I smell is dog pee, sorry. Heat.
You turned your heat on?
Oh,
Oh,
his glasses look like
Hello.
yours.
They sure do. Hello.
Hey,
Can you hear me?
Daniel.
Hi.
All right. It's been a while. How you been?
I'm alright. Thanks for asking. How are you?
Good, good. So, yeah. I didn't send her anything.
Yeah, as soon as there's an email, the office meeting the link.
Oh.
Okay, got it.
Yeah, we're just sending a link over to Dr. Shubin's office.
Oh, awesome.
Oh, cool.
Still give it a second. Who's Nikki Owens?
Oh, I thought that was on your end. Nobody we know.
Okay. I wonder if Nikki's from Dr. Shubin's office.
Yeah, I sent her office a link about 20 minutes ago to join. Yeah, we're live.
That's interesting because I also have a meeting that from her office on Friday at 2:15. So
Dr. Shubinstein's going to be on in just a second.
Oh.
I just spoke with her. Sorry for the delay.
Awesome.
You're from Beth's office?
Yes, I'm Dr. Shubinstein's athletic trainer.
Okay, great. Awesome. There we have it. They did get the link.
That's great.
Yeah.
It's nice when a plan comes together.
Isn't it? So you had a meeting also scheduled for Friday with her?
Yeah, that's what somebody from her office reached out and said to me.
Oh, okay.
Email.
Well, it sounds like she's going to be on now.
Cool, I did not know that.
You figured it out. That's good. Yeah, that was kind of the idea.
Well, that was
Because,
what I was looking for.
the way we left it was a while ago, was that we do kind of a two-pronged approach, which would be to get your patella aligned and in order. And then, once that's reduced and your knee's more stable, then we could actually lengthen your femur, get your knees at a similar level. Let's see the x-ray here again. So we have a long x-ray here. And then do a more, conventional amputation, which would be like mid-tibia-ish, and get you into a baloney prosthetic or an osseointegration. Now, have you looked into the osseointegration since we talked?
Yeah, I have quite a bit.
What do you think about that?
I think the pros are a lot over the cons of it, considering a lot of my issues with heat and weight bearing and sores and all the conventional socket issues.
Right.
Yeah.
So you're interested?
Yeah, I didn't know for a while that it was an option until I went through and watched a lot of the videos and reread it and noticed that you did say it was an option partially for, because I didn't know if I had enough, would have enough build height or lower limb left, I should say.
Right.
Okay. Hi, guys. Sorry for the delay.
Hey, Beth, Dr. Shubin's not
Hey.
on.
Hey, guys.
Hi.
Hi.
We didn't know you
All right,
were
I'm
going to be on, so we're thrilled.
Oh, no, my apologies I was trying to get the link through the invite, but I couldn't find it, so. All right.
So, yeah, we're putting this meeting together just to try to touch base and figure out, if we all agree on a plan.
Yeah.
I remember, so you've met Daniel, right, in the office before?
Yeah, Daniel, when Nikki, is Nikki on, by the way? Nikki, are you on? So Nikki has access to my notes, which I don't have right
Doesn't
now.
look like she's
Nikki
on the
was
call
on.
anymore.
Yeah, she cut off to try to get me the link.
It was
So hold on one
it was May 20th of last
That's what I
year.
thought. I knew I was just trying to find the dates. Okay. So I'm going to actually, as we sit here, hold on one second. I'm going to bring up my notes and also your imaging so we can kind of all be on the same page at the same time. So hold on.
So we'll just review that Daniel has congenital short femur, a congenital knee patellar dislocation, congenital absence of ACL, and also has fibular hemimelia with a short tibia and a sign amputation.
Okay, and then, and I'm just going to look back at my notes, and I'm going to read what I wrote from my notes. Hold on, I'm just logging into Epic, Daniel. At first, I want to bring your imaging up, so give me 1 second.
Great.
I can share the imaging too. I have that here.
No, I got it. I'm just bringing it up right now.
Okay. The other thing, Daniel, is, most people like their knees to be the same level, but if you didn't care about that, then you could do the osseointegration of the tibia and not lengthen your femur and just have a longer prosthetic. So that is an option, like, you don't have to lengthen your femur.
I think a lot of my bodily composition problems come from the imbalance of my knees, though, because I do have, 3 inches or so of a discrepancy. Yeah. So that's kind of like I would live the rest of my life in a standard socket if that was my only option, and then if I could have my knees in balance. But there's also, like you were saying, what were you saying with the most to lose or whatever thing?
Oh, that quote?
Yeah, from the other video.
Yeah, we've been watching a lot of videos, but there was a really good quote that said, "It is the hardest decision for the patient who has the most to gain." So he really has nowhere to go but improvement, so it's just trying to find the best thing for him.
Yeah, okay, fine. I would think that you'd want to level your knees as well.
Yeah.
But I figured I'd throw that out there in case it's just too much. Because it's a pretty big reconstructive plan with basically 3 different operations.
So that's kind of what I was wondering, what would the process be with the knee surgeries, and how far along would I have to fully heal and whatnot from that to get started on anything else?
So the issue with lengthening the femur.
Hey guys, sorry. When I'm in for whatever, I just wanted to come in for 1 second. When I'm in your Epic chart, Daniel, for some reason you guys can't hear me, so I don't know why, but so I'm listening, but I'm in your Epic chart and I'm just looking at our last note. So Austin, why don't you keep talking? I'm going to finish reading that. I can't read it to you guys because unfortunately you can't hear me when I'm in your Epic chart. So, but I am listening.
Very interesting.
Okay, great. Yeah, so I think it's important for Dr. Shubin to hear this too, is when we lengthen the femur, it puts a lot of stress on the knee joint. And if the knee joint is ligament deficient, then it can dislocate. You can actually dislocate your knee. So the more stable we can make the knee before lengthening your femur, the more successful the femoral lengthening will be. That's a kind of important concept.
Right.
We want to keep you stable. Now, the good news is that the lengthening puts more stress on the PCL, which I have to review. I think you have a PCL and you just don't have an ACL.
So I'm in here and I'm looking at your imaging. And when you and I spoke, which was I think it was May 4th, I was just looking at it. We did not have imaging to work from. For whatever reason, it wasn't in the system. So the last imaging I have available for you, Daniel, is from March of 23. Does that sound right to you?
Yes.
Yeah.
Okay, so it's going to be over 1.5 years old, and so we will need new imaging, but we can certainly look at like making a plan from these imaging. So I'm looking, and yes, so the concept, and I think Austin, kind of correct me if I'm wrong, the right knee is how many, about 5 centimeters shorter than the left? I mean, in terms of more proximal, the right knee hinge is about 5 centimeters, it looks like from the x-rays, more proximal than the left knee. Is that about what you see, Austin?
It's even more than that, honestly.
Okay.
I remember
So-
9 centimeters.
These are uncounted images, but
Yeah.
just roughly, yeah, you're looking at 3 inches.
Okay. Okay. So 3 inches, 6 centimeters. Okay.
6
So,
centimeters.
there's a couple things that I see and that we wanted to look at, and I'll still need more imaging on this. And I think we can start to think about what imaging we need to make a final plan. But essentially, your plan is to lengthen the femur to get the hinge at the same level. Is that right?
Right.
All right. And then the other plan, which I heard, but I'm not sure kind of when time-wise that would happen, is the osseous integration into the tibia for the BKA, for the below knee amputation prosthesis, right? Is that going to occur at the same time?
No, I would do that last, actually.
Okay, so you're first going to lengthen the femur. Is that correct?
Right.
Okay. So from my perspective, we need some imaging. This is where I'm so sorry that Nikki's not on, because I'm going to write this down and then we're going to work on it later. With you. Oh, great. Sorry. I didn't, when I said hello, Nikki, before, I was like, okay, so great. Nikki's on. So I'm looking at the imaging now with Daniel and with Dr. Fragomen, and we're just trying to figure out kind of stage wise when Dr. Fragomen does the femoral lengthening. And, you know, Austin, you and I share a patient who you did this with, right? So we delayed what we were going to do with the patella until the femoral lengthening was complete, only because obviously things get tighter. I do think that you have a very proximal, so you have significant what's called patella alta, Daniel, which means your kneecap sits high and dislocated. It's a chronically dislocated patella. So at the time when Dr. Fragomen does the lengthening, I do think it would actually help the lengthening for us to do all of our lateral releasing. So lateral lengthening at the same time. So releasing all the soft tissues around the patella. Mm-hmm. I might even consider, depending on how it looks, putting in the MPFL at that point. The MPFL actually shouldn't change. No, that's not true, because what I want to do is allow the patella to move with the femur as you lengthen the femur. Yeah. Otherwise, this will become more proximal, more tight, more difficult to kind of get back to where it's supposed to be. Absolutely. So I think that should be a joint surgery. I'm probably just going to do soft tissue releases at that point. I'm not going to do anything. Well, actually, I could move the tubercle, because the tubercle isn't going to change. The tubercle will not be affected by the lengthening.
Right.
Yeah, I might try to get the patella in place. Now, how quickly are you planning on lengthening it, Dr. Fragomen? Austin, how long does it take to get that 3 inches?
It takes quite a while, a millimeter a day for 80 millimeters. So take about 3 months of lengthening, and then another 3 months for the bone to consolidate.
That's actually fine, because what I want to make sure of is there's not unnecessary pull on the tubercle. So if I move the tubercle at the same time, the tubercle should be healed by the time that real pull starts. So that actually might help to tether the patella and like keep it down a little bit. Mm-hmm. So I would plan, Nikki, on a tibial tubercle transfer, large lateral lengthening. The only thing I wouldn't do is put the MPFL in. And the reason I wouldn't put the MPFL in is because I really do think that may change dramatically as you lengthen the femur. So we would come back to do the MPFL and hold the kneecap in the right spot. I'll make that decision at the time. And the only reason is obviously because the quad is going to be under a ton of stress. Yeah. The quad is going to lengthen. And my concern is, as the quad lengthens, it pulls the MPFL. I think the tibial tubercle will be fine. I mean, the attachment, by the way, also by definition will be lengthened. But again, I think the tubercle will be healed by the time most of that stress comes on.
I think it would be smarter. Well, let's just say it's safer if we delayed the lengthening for at least a month or 6 weeks, so that the tubercle was really pretty well stuck before we started yanking on it. Because he may be quite tight, and he could get tight within a couple of weeks, and it could literally pull apart your tubercle.
Well, that's what I'm concerned about. In which case, I don't have to do the tubercle at that time. I can just do all the lateral lengthening and the releasing of the tissues and get the kneecap to kind of be more mobile. Mm-hmm. I can put in some type of soft tissue tether, but not anchor it into bone on the medial side. I could even sling it around the adductor tendon or something, just so that there's something holding the patella kind of where we want it while the lengthening is occurring. Mm-hmm. But I don't want to do the bone fixation till after the bone is lengthened. So maybe I'll avoid the tubercle altogether, and I'll avoid bony fixation on the medial part of the femur. And what I'll do is do what's called an adductor sling. And that will allow some stability of the patella, meaning just holding it kind of around the front of the knee while we're lengthening the femur, and then doing the final, making sure the patella sits. We do need a CT scan, so that's what we're missing. We need a CT scan, and Nikki, CT of the knee, proximal to the patella, so they have to move. It's knee plus kind of distal femur, and we would need a 3D reconstruction on that, so I can see kind of how much bone we have on that patella. Mm-hmm. And then I think we will do a soft tissue MPFL with the ultimate goal of doing a real MPFL once the lengthening is completed, and ultimately also probably transferring the tubercle once the lengthening is completed. But I think you're right. If there's any delay in union, and it may even cause further delay because of the fact that we're constantly moving. There's constantly motion at that level. So no tibial tubercle, no femoral fixation on the MPFL, but we'll do an adductor sling, Nikki, some type of soft tissue sling for the MPFL. We will do that at the time. Question for you, Austin. If I use a donor graft, will that affect, if the donor graft on the medial side while you're doing the lengthening for your femur, that shouldn't affect you, right?
That'd be fine. Yeah, no problem. Okay.
All right. So we'll use donor, Nikki. So again, just so you guys know, Daniel, what I'm really thinking about is how do we get your kneecap? If I'm concerned that if Dr. Fragomen does the lengthening, that it pulls the patella even further out of place and makes it even harder to get back into the right place after we're done. If we can release some of the tight tissues now and give it some type of tether to hold it down while you're doing the lengthening, it makes our second approach when we're planning on actually moving and getting the kneecap kind of located in the front of the knee. That will be easier if we've done some of this preliminary work before the lengthening, just because we're moving it so much.
Okay, I see. So
it's really soft tissue. I wouldn't do anything in the bone just because the lengthening is going to occur.
The other thing, Daniel, is, we would go for it's roughly 8 centimeters of length. It's very possible that when we hit 4 or 5 centimeters of length, that your knee starts to dislocate. Now we'll do bracing to try to prevent that, but if that does happen, then we have to slow down the lengthening or stop the lengthening, because I can't have you dislocating your knee. So basically, Beth, the tibia subluxes posteriorly on the femoral condyles with these congenital knees when you lengthen the femur, the hamstring.
Because the condyles aren't shaped correctly, right? So there's nothing, and so it'll slide. So the tibia is going to slide posteriorly on the femur.
Slides posteriorly, and so an extension.
Is there a reason to put like an X fix on it? Was it worth putting some type of X fix on while you lengthen it, just to tether as a backup to the ligaments?
You can. It's nothing's free, right? You put an X fix on, they get incredibly stiff and problems. And I want to do the lengthening with an internal nail, and then how do you get the pins around the nail? It just becomes difficult, but usually extension bracing will be enough, like a dynamic extension brace during the lengthening. But the point is that we may not get the full length we want. If it starts to sublux, we can have that discussion about going back and putting an X fix on at that point.
Okay.
It may not be fine with the extension bracing, but it's another thing to consider. We may not get the
I think for that reason also, getting the patella in the front of the knee and releasing some of the soft tissues will give it a little bit more play without as much pull on the tibia, because a lot of these tissues attach straight to the tibia. So if we can release a lot of that when we're in there, I think that may actually help.
Have an anterior pull, lengthen will balance the hamstring.
Yeah, so it's not sitting as a lateral tether.
Right.
Okay. All right, so Nikki, from our end, I think it's worth getting an MRI just because we don't have one. So MRI and CT with 3D reconstructions that goes proximal to the patella. right. So I think, you know, I don't know when you're thinking about timing wise for this, but like I said, I think we'll do as much of the soft tissue stuff as we can at the time, and then we'll watch the patella and what it's doing as you get longer, right? As the length occurs, we'll periodically take a look at where the patella is sitting. But we'll correct it finally at the end once you're fully lengthened. And the nice thing, because you're lengthening through the femur, is you won't have to wait like our other gentleman lengthened through the tibia. So we had to wait in order to do his tibial tubercle. So, so this won't affect the tibia, meaning as soon as you're done and you feel like the bone is consolidated enough, we can address the tibial tubercle.
Great. So, Daniel, where do we stand with your insurance? Because you're sort of restricted to staying in state, no?
That's a good question. I believe Beth signed up last year for the whatever it was to do an out-of-state.
Yeah, Dr. Shubinstein was working, I guess, with a worker from Daniel's Vermont Medicaid, a nurse there, and they were willing to do a single case agreement for Daniel because we went to Burlington and talked to the ortho people there. We went to Dartmouth and talked to the ortho people there, and they both signed letters saying his case was too complex, that it should be done at HSS. There was no one in his network that could do it. So our understanding was Dr. Shubinstein has already signed up with Vermont Medicaid, and I don't think, well, so I don't know. I am not signing up with anything that's a Medicaid. What I have done in the past, because I've treated lots of Medicaid patients, but I do it just without charging. I don't actually sign up for the Medicaid. And the reason is because then I would then get 100 patients with Vermont Medicaid who would then want to be in my practice. Right.
And, you know, I only do this for complex cases. So we don't actually sign up with Medicaid. We just agree to accept non-payment. Essentially, we don't get paid, which is fine with us. We do it all the time. But there's not going to be, just so you're aware of what the logistics are, we don't sign up with a plan.
But if we can get a single case agreement, then that basically means that Medicaid will pay HSS, which is the big deal, and pay our offices, whatever rate. But that's really important, because if HSS doesn't get paid, they won't do the case,
So that was what got us stuck last year, and why it took so long to get back in touch, because we got all of this wonderful sounding awesome stuff from you guys, and then it was like to work with the financial people, they just kept saying, no, it can't happen, no, we don't do this, and so we're kind of stuck on that end.
Who did you speak with Ross Sadler?
I don't think so.
Okay, so call my office and speak with Ross. He'll help you. Ross Sadler, Sadler. Nikki, can you let Erica know to give Mom all the instructions on Ross? Because Ross is the guy who deals with all the finances from HSS. Okay. He also deals with charity care and financial aid and all of that stuff. So he just knows the workings of this stuff.
Okay. The other important thing is Daniel got approved for disability, which meant he got his insurance changed recently to Medicare, but I'm sure that's the same situation.
No, I take Medicare, actually. Medicare works. So Medicare is actually a great payer for the hospital, and I have always taken Medicare. So that makes things way easier if you're on Medicare.
Wonderful. What about
so
you,
just
Dr.
talk to Mr. Sadler. Okay. He'll know. He can see that I'm on Medicare. He can see I'm a Medicare provider. So he'll be able to work with you. But it's most important because the hospital takes Medicare.
Right, so it's the Part B, A, B, that whole
and
deal.
Take Medicare. Okay. So,
but what about Dr.
So
Fragomen?
deal with Mr. Sadler. He'll help you with all of this stuff.
Will he help you with Dr. Fragomen's part of it too, or how does?
Yeah, we'll work it out.
Okay.
Absolutely.
All right. Oh my gosh! Wow, this is like Christmas and Easter and.
I have a question about the lengthening. You were saying it could only go potentially so far?
Right, that was my question.
Right, it depends what problems we run into. But if your knee starts to dislocate and it's because we're lengthening, then we have to stop lengthening, right? And give your soft tissues a chance to stretch out.
Okay. Right.
And sometimes it just takes a few weeks and then we can resume lengthening. Other times we have to completely stop. Other times, like Beth said, we'll have to do more surgery, put an external fixator on. really, and continue lengthening, but then you're gonna get really tight. So we have to be a little bit careful about that. Sometimes the tissues won't allow for a full 8 centimeters, and we break into 2 separate lengthenings, you know, a year apart. I mean, it can vary a lot, you know, or we accept that the knees won't be exactly the same, but they're a lot better than they were. You kind of got to roll with that one.
Yeah.
Okay.
Yeah.
It's a lot of information.
Yeah.
So timeline, what do we, is that up to Daniel or?
Yes, I mean, you guys need to tell us roughly when you want to do this, and then we work backwards and confirm that we have all the authorization from insurance and all that.
Yeah. So were you thinking on your end, like the end of December kind of thing, or?
Yeah, I mean, somewhere in the next little bit.
I'm going to just suggest that we do this in January, and I'm going to tell you why. My schedule, and I know true for Dr. Fragomen as well, no months are ever busier than November and December,
Okay.
and that includes always a week of vacation for me and my family, and I'm sure for Dr. Fragomen just because of the holiday season. So if it's mandatory that it happen before the end of the year, we will figure out a way to make it happen. But if it is not mandatory, I really would push this to be in January. It's just a way easier booking with the OR, with time, with finding coordinated time between Austin and myself, building in 2 surgeons to the same case. It's just going to be much easier.
That makes sense. The optimal results are better when people aren't taking vacations and everyone is fully staffed. So that makes total sense.
Yeah.
It's true.
And the hospital, it's not just Dr. Fragomen and I. The hospital itself does nearly twice our monthly volume in November and December because of the way that insurances work with meeting deductibles. And so just everybody is stressed in November and December trying to get the cases done. So it is better for a case like this to do it when you, as we said, in the new year.
Okay, that makes sense.
So if we were to confirm a day or a time or something like that, when you with the whomever, is that when the scheduling could work backwards with the insurance, like you were saying?
Yeah.
And then
We'll look for a date in January. We can start that now, and then we confirm the insurance bit.
Okay.
Now, as far as imaging,
That was my other question.
Oh, go ahead.
Is that something that can be ordered? Like I can get it and then have it sent over like I had done before when I came to see you in March. I had gotten imaging done and then sent it over. I don't know if that's helpful.
I think the CT, it is easier to figure out what imaging we need and then get it all done by coming down here to get it done.
Okay.
It's much easier when it's in our system. It means there's no room for error in terms of things getting transferred over. So my personal opinion is, pick one day when we know exactly what imaging we need, do it about 3 weeks beforehand. As long as it's done within 3 weeks of the surgery, it'll give us time to look at everything and look and see if something is changing. But it should be all done here. So and Mr. Sadler can help you arrange that as well once we get the finances figured out.
Okay.
But better to have everything done on our system.
Awesome.
Okay, great.
So
you would time that with your meeting with the medical doctor and getting blood work drawn and all that.
Like pre-op stuff. Is that what you're talking about?
The pre-op testing, yeah.
Yeah. So that he could do with his local primary care doctor.
No, he has to do it down here.
Oh,
Because
what?
we have to admit him overnight.
Oh, okay. So down there. All right.
So you can do it all in one day.
Okay. Oh, awesome. Yeah, that makes total sense. Yeah.
That's all I got. That's all my questions. What would the osteo integration look like as far as like prosthetic fitting stuff in the future? Is that I return to my local prosthesis and try to learn that type of stuff? Or
Well, only if they work with that type of prosthetic. Otherwise, you'd have to come down here and work with our guys.
Okay.
Certainly, the beginning, you start with our people,
Right.
and then for basic prosthetic needs, you could probably see someone local. But if there's a connection issue with the OI connector, then you probably have to come down here for that.
Right.
Okay, so it sounds like first thing is a joint case with Dr. Shubinstein and Dr. Fragomen. Dr.
Yeah.
Shubinstein's going to do some releasing, and then you start the bone lengthening, and then
Right.
we just have to go from there and see how his knee reacts to all of that.
Right.
So there's
Right.
different time scenarios, you know, best case, and then there might be some hiccups, and then eventually, when do you decide whether to, if the osteo versus the socket thing, like where does that come in the whole time frame?
Or is that just a decision I?
Yeah, you make that decision beforehand,
Okay.
and then that surgery is, you do one or the other, you know? I mean, based on what you're telling me, the osteo is the way to go here.
Do you have a recommendation from your expert?
Well, from all the literature they've been posting, it seems most people prefer osseointegration, and it has a lot less cons with the sweating. And
Yeah, I mean,
Oh, yeah.
to me it seems like a no-brainer, but I'm just a lay mom person, so.
No, it's really good. It's lighter, too. Red socket's pretty heavy. So, yeah, we'll cross that bridge. Let's get your knee stable first, and your knee height's better.
Yeah.
Okay.
So next steps, what next?
Next
up,
step.
I think you guys have to speak with Mr. Sadler.
Yeah.
You guys have to get things sorted with Mr. Sadler and the
Yeah.
finance.
Yep.
Once we have that sorted, then you need to work with Kathy and Erica, and they'll figure out a time. And Nikki, can you let Erica know we're talking about January? And that way she knows kind of where to look for time with Kathy.
Yep.
And then Nikki has the orders, and we're putting them in as far as the imaging. And as soon as you get the okay from Mr. Sadler, then you guys have to go ahead and figure out a day to come in and get the imaging and get the lab work and all that stuff. And again, that can be done 3 weeks ahead of the surgery.
Okay. And is that's when is it ideal for you? 3 weeks is fine, or would you rather it be done sooner?
So they need the blood work. They need the blood work within a month, and I wouldn't want you to have the imaging less than 2 weeks, just because it doesn't give us enough time
Okay.
to coordinate
All right,
work.
so
So
that
I would say
3
around
weeks
3
is
weeks
good.
is kind of the ideal time.
Got it. Makes sense.
Right.
Well-oiled machine. Okay.
Good. We have a plan.
Yeah.
Sounds good. All right.
Okay.
Anything that changes, let us know. Obviously, if there's any problems dealing with Mr. Sadler, Nikki, can you make sure that they get in touch with Mr. Sadler? Erica can help them.
Okay.
Okay. Terrific.
Thank you. So
All right,
Erica
great.
is your OR scheduler, right? Dr. Schubenstein, and then Kathy Torres is Dr. Fragomen's OR
Yes.
scheduler.
Yeah, I'll get in
Yep.
touch with Kathy.
Yep.
we're
And
good
Nikki
time.
is your physical trainer, you said. Yes? Yeah, okay.
Okay.
Sorry, got it. I think.
Okay.
All right.
Excellent.
Okay. Bye, guys.
All right,
Bye.
Daniel. Good seeing you. Thank you, Beth.
Good seeing you guys. Bye.
Thank you.
All right.
Bye.
Meg.
I'm gonna lose my shit. Oh my god. Why did we freaking know this last year? I mean, it's kind of a she says it like it's, why